Clinical Journal Club for this week in English. The image in the New England Journal concerns this 68-year-old man who's had a 2-day history of neck swelling. He had earlier had a toothache, and his condition is characterized by fever, progressive difficulty and pain on swallowing both solids and liquids. So this is an acute problem associated with a dental problem. Cancer and IG4 related disease are chronic. I would think that if he had a stone in a salivary duct, his problem would be more localized and have a different mode of onset. So we're stuck with Ludwig's angina, and this is an acute infection in the submandibular space. So these are fascial planes. This can rapidly progress and in essence can be lethal. So this is a medical emergency that requires immediate attention from oral surgeons and people that know how to handle this kind of problem. So here's an image of the oropharynx and what it looks like when you ask a normal person to open his mouth. A tumor would be a chronic condition, and this is an example of carcinoma of the tonsil, has an entirely different presentation. Stones can form in submaxillary ducts. They have an entirely different kind of clinical presentation. They could conceivably result in a submandibular abscess and also present as a medical emergency, but I think the history of this patient is different. So this condition, actually in English, is called Ludwig's angina. I was not able to find out who Ludwig is, because I think in German this is generally just referred to as a severe infection of the submandibular area. But this is a medical emergency that requires immediate attention and probably other imaging modalities. Now, in the New England Journal, our attention was drawn to the fact that esketamine has now been approved by the FDA for the acute treatment of resistant depression. And you'll recall that ketamine is in essence a racemic mixture of two stereoisoforms. This is actually the ketamine isoform on the left, and this is esketamine on the right, which is substantially more potent in its action. Now, this compound has been around for about 40 years. It was popular particularly in the Vietnam era because it can be given quickly to wounded personnel, and it was actually introduced as an analgesic agent. Now, ketamine has gained a notoriety as a drug of abuse, which is a potential problem. And if we look at the effects of randomized trials comparing esketamine to oral antidepressants, esketamine seems to be better, but I don't think the results are particularly dramatic. And the results of these other trials, although they are statistically significant, I, as a non-psychiatrist, probably would not think that they're dramatic. Another issue that troubles me a little bit is that, as far as I know, electroconvulsive therapy with appropriate analgesia, etc., has been shown to be effective for resistant depression in a number of well-done randomized clinical trials. And I guess I would have liked to have seen a comparative study comparing esketamine to electroconvulsive therapy. Another commentary in the New England Journal involves the use of ultrasound in Ebola treatment units, and physicians that work in these units, instead of the usual white coat and tie, etc., have to dress in this rather cumbersome series of suits to protect themselves. And the physician that wrote this editorial here comments on the extreme value of bedside ultrasonography in examining these patients because of the usual items of inspection, palpation, percussion, and auscultation with a stethoscope are not possible in this hospital setting. So bedside ultrasonography is very helpful here. Not mentioned by this physician is that modern ultrasound probes are now available. They're not too expensive. You can just put your iPhone on them and see your image immediately. And these kinds of devices are going to replace the stethoscope, and in my opinion, for good reason. In Europe, the training for young physicians in terms of ultrasonography is excellent. And it's expected that all physicians should be able to perform ultrasonography and not leave this capacity to some sort of specialized imaging persons that are unlikely to be very tempted to come into intensive care units. The first topic in the New England Journal concerns prostate cancer, and this is a complicated problem because it's so common. And the strategies that are involved here require imaging and biopsy and categorization of how aggressive the tumor is in terms of a pathological evaluation of the tissue in terms of a Gleason score, and then decisions are made. Radical prostatectomy is generally performed in men with prostate cancer, and then decisions have to be made in terms of what can be offered to the patient subsequently, if watchful waiting is appropriate, or if radiation therapy should be performed, or if an endocrine treatment directed against testosterone should be initiated. Then there are patients that have progressive metastatic disease despite endocrine therapy, and this situation is referred to as castration-resistant prostate cancer. A somewhat unfortunate term in my view, but whatever. The treatments that we have, endocrine treatments that we have available involve GN receptor agonists or androgen receptor antagonists such as flutamide. There's also the possibility of blocking testosterone synthesis with abiraterone. Abiraterone blocks the synthesis of the testosterone, but it also interferes with the synthesis of glucocorticoids, which is a potential problem. Now, another possibility that one can consider is new androgen receptor axis targeted drugs. And Apalutamide is an example, and this material binds specifically to the ligand-binding portion of the androgen receptor, which then impair or eliminates the possibility of the internalization of the androgen receptor and its subsequent DNA signaling. This process then is blocked to a substantial degree. One problem that's mentioned in the editorial in the New England Journal is that, at least in the United States, this treatment with apalutamide costs about $10,000 per month. Now, in this study, patients with metastatic castration-sensitive prostate cancer were randomized to treatment with apalutamide compared to usual care, plus a placebo for the apalutamide administration. And the primary endpoints were radiographic progression-free survival and overall survival. So there are over 500 patients in each group, and their functional capacities were really still pretty good. Their Gleason scores were generally greater than 7, and they had undergone radical prostatectomy. And some patients had already been treated with docetaxel, which is commonly given for patients with prostate cancer, and but the randomization was successful so that the clinical characteristics of the patients in each of the groups is similar. And what we see here is radiographic progression-free survival was significantly better in the apalutamide group than in the placebo group, a highly statistically significant difference. And the various subgroup analyses seem to suggest that all the patients with prostate cancer were amenable to this treatment. What was also impressive was that overall survival, death from any cause, overall survival was better in the apalutamide group compared to the placebo group, and that also seemed to be the case for most of the subgroups, perhaps with the exception of whether or not the patients had already had docetaxel. So in this study, overall survival was improved by the apalutamide therapy. And the median time to the requirement of any other cytotoxic drugs was better in the apalutamide group than in the placebo group. And in terms of adverse events in these patients that were getting endocrine therapy anyway, there was no significant difference between the two groups of patients. And individual adverse events are given here. And they were also acceptable. What we also observe is that the time to the initiation of cytotoxic therapy was better in the apalutamide group, and in terms of PSA progression, this was also substantially better in the apalutamide group. The next topic in the New England Journal involves a autosomal dominant genetic disease, achondroplasia. This condition is not that common, but it is dramatic because these patients have a problem with their cartilage bone in terms of the epiphyses fusing at far too early an age. As a result, their thorax is not compromised that much. The head seems fairly normal in size, but the obvious change in the short stature and the change of length and long bones is obvious. And this disease involves a mutation in the FGF fibroblast growth factor receptor number 3. And to my knowledge, this is an autosomal dominant disease. It is an autosomal dominant disease, and it involves increased signaling through the FGF receptor 3. Now, what I didn't know was what I'm going to show you now. And the illustrations here involves natriuretic peptides. And these were first described as being formed in the atrium. I had an occasion to work with some of these problems scientifically. Urodilatin is formed primarily in the kidney. Brain natriuretic peptide was first described in the brain, but it's also made in the heart. And most of these peptides are actually synthesized by endothelial-like cells. There's also C natriuretic peptide, which is also secreted by vascular endothelial cells, but can also be formed elsewhere. And as their name implies, these hormones result in natriuresis and peripheral vasodilatation, but they also have other substantial effects, some of which I was not aware. And plasma C-type natriuretic peptide is involved in disorders of skeletal growth. And that was news to me because one of the targets of C natriuretic peptides is cartilage, and cartilage obviously is involved in the formation of cartilage bone. And what we see from here, from this illustration here, is that there's an interrelationship between fibroblast growth receptor 3 and the C-natriuretic peptide receptor. C-natriuretic peptide results in the generation of cyclic GMP, which has an influence on the MAP kinase signaling pathway that's elicited by the fibroblast growth factor receptor 3. And there's also an interaction here in terms of MAP kinase and ERK signaling, inhibiting the formation of GTP to cyclic GMP. So there's an interrelationship between these two signaling mechanisms. And in this particular study, in these young patients with achondroplasia, is the application of a C-natriuretic peptide, a synthetic biological analog of C-natriuretic peptide called vosoritide. So vosoritide was given to these young patients with achondroplasia in a series of different doses, and obviously we're excited about whether or not it causes these patients to grow faster, but this study was actually a safety and side effect profile study, because we could imagine that C-natriuretic peptide receptor stimulation would have substantial cardiovascular effects as well, since the receptor is expressed on various tissues and not only on cartilage. So these patients were given different increasing incremental doses of the C-natriuretic peptide analog, and they were observed for 6 months prior to the administration of compound, and then 2 blocks of studies involving 6 months and 18 months of observation, and subsequently there is to be an extension study so that we can observe what is the final adult height of these patients with achondroplasia. So here are the patients, and this is not a terribly common disease, so that they were recruited worldwide. And basically, these are children under 14 years of age, given this C-peptide analogon at various doses as illustrated here, up to 30 micrograms per kilogram. This material has to be, this is a peptide, so it has to be injected subcutaneously, and so we might expect injection site erythema. That was indeed the case, but actually the side effects, I think, were not dramatic. 3 patients had problems with obstructive sleep apnea, but perhaps that was related to their primary disease. 1 patient had tonsillar hypertrophy, but there are also various reasons to have that reaction, and the adverse reactions in terms of cardiovascular effects were not apparent. So the fear that hypotension would result and tachycardia and other sorts of problems, or perhaps increased natriuresis or volume contraction, that was not the problem in this observational study. Now, if we look at the annualized growth velocity of these patients, and that's not the primary endpoint in the study because this is a safety and efficacy study, we can see a dose-dependent increase in growth velocity compared to the baseline 6-month period of observation with the subsequent observations through time. Now, we're not given absolute heights, so that I can't tell you exactly how much these patients grew, and there's no non-treated control group. So what will eventually happen to these young people when they become adults in terms of how much taller they get, we don't know. These changes in height are based on z-scores, which is a standard deviation compared to controls and at a specific age. And indeed, there is an increase in growth with the administration of this compound. In terms of what this effect will be over time, I guess we'll have to wait for a subsequent report. We would also expect that C-natriuretic peptide would result in the increase in cyclic GMP, and that was also the case, and these changes are shown here in a dose-dependent fashion. And there are also markers of cartilage that we can look at here, and they also increased in a dose-dependent fashion, so that it appears that the pharmacological effects of this compound is given. So once daily subcutaneous administration of vosoritide was associated with a side effect profile that appeared to be generally mild, and treatment resulted in a dose-dependent increase in annual growth velocity for up to 42 months of observation in this study. The next study in the New England Journal involves membranous glomerulonephritis, which is a fairly common form of glomerulonephritis that results in end-stage renal disease. And the pathogenic mechanism here is the development of immune complexes that then deposit in a subendothelial fashion against the basement membrane in these patients. The antibody that's involved here is an IgG, and in about 75% of patients, the antigen is the phospholipase A2 receptor type M, a finding that was discovered about a decade ago. There have also been other antigens discovered, so that this is one of the not too common instances where we know the antigen and we know the antibody that's involved in this particular form of glomerulonephritis, and the electron microscopic appearance of these deposits are well known, and those are shown here. And then there's a herniation of connective tissue between the deposits that can then also be seen on silver staining, which is fairly typical for this disease. Now, whether or not treatment for this disease is effective is debatable, but these patients are generally given an immunosuppressive course with cyclosporin, which seems to help them. There have been numerous trials performed on this issue, and cyclosporin at the moment is the primary treatment for patients with membranous glomerulonephritis. Now, in this particular study, patients with biopsy-proven membranous glomerulonephritis were randomized to either cyclosporin or treatment with rituximab, with the idea that an anti-B cell therapy might alter the formation of antibody in this particular condition, and maybe that treatment would be a better idea than giving these patients cyclosporin, which has a number of inherent problems of its own. So there are 65 patients in both groups. 65 patients got rituximab and 65 patients got cyclosporin. And we look at their characteristics, and the randomization here was quite successful. About a little less than around 75% of the patients were PLA2 receptor positive, which we would expect. And their creatinine values are slightly elevated, but not so bad. And their urinary protein values are given here, 8-9 grams of protein per 24 hours prior to initiation of treatment is impressive. And we'd like to see what happens to them. So the initial hypothesis in this study was that rituximab is no worse than cyclosporin, non-inferior. But as a matter of fact, it looks like rituximab was quite a bit better than cyclosporin. And in terms of driving patients, bringing the patients into remission, and for the remission to be sustained, this result was substantially better in the rituximab group compared to cyclosporin, and that result is shown here. Now, rituximab is not a cure, but it looks like 75% of the patients in the rituximab group had a sustained remission without exacerbation compared to the cyclosporin group, which did substantially worse. And in terms of the incidence of adverse events, cyclosporin is not harmless, and basically there were no differences in terms of adverse events comparing these two treatments. So the rituximab group, at least in terms of adverse events, did as well as the cyclosporin group. So if we do an analysis in terms of superiority, it looks like rituximab beats cyclosporin, so that we could perhaps imagine that this treatment is going to be a game changer, if I can use this awful American colloquialism, in terms of treating patients with this fairly common form of glomerulonephritis. Now, there are also other options that one could imagine. There are more modern inhibitors of B lymphocytes, which is one strategy. We might also want to inhibit plasma cells that are responsible for antibody formation. There's an antibody available for CD38. So I think we're going to see a series of different kinds of treatments offered to patients with membranous glomerulonephritis, and the results should be quite a bit better than treating these poor patients with cyclosporin. The next topic involves phage. Phage are DNA viruses that attack bacteria, and they have been known, they've been around probably for 1 billion years, but we've appreciated them for about 100 years. The ability to see phage had to wait for the development of an electron microscope to actually see what their structure looks like. But what we see here in this particular plate of bacteria plated on this petri dish is when phage are administered, the bacteria are destroyed, as seen by this plaque here. Now, with the introduction of the electron microscope, we see that the phage virus has a head that contains its DNA, and then it looks rather like a moon lander. It lands on the surface of the bacteria and injects its DNA into the bacteria, which then results in the formation of more phage so that the bacteria burst. And T4 was the favorite phage of Max Delbruck, whose research was largely responsible for elucidating the molecular mechanisms of phage viruses. Now, the technology that I'm going to tell you about is the so-called phage display. And the technology involves the incorporation of genes into the phage, genes that code for protein, with the feature that there's also a bit of the protein or amino acid sequence, peptide sequence, also present on the surface of the phage. So, as a result, the entire human proteasome, that means all the peptides that humans produce, can be expressed in a phage library. And then these phage libraries can be amplified by using E. coli, which attack the phage. They die in the process, but then there's a massive amplification of the amount of phage that features peptide expression on its surface and also the genetic material in the phage DNA, so that this is also amplified. Now, this technique allows us to find protein-protein interactions, because then we can precipitate phage with target antibodies. And if we are dealing with an antibody where we have no idea what the antigen could be, such as an autoimmune phenomenon, we can then find out what the target protein is of this particular autoantibody by the use of a phage display. And there's a small review in the New England Journal. There was the Nobel Prize for Chemistry in 2018 was given to George Smith and Greg Winter, that are responsible for the development of this phage display technology. And there are various kinds of phages that we can use here. There is a favorite is this filamentous phage, and we can see that there's a foreign peptide sequence, then there's a modified coat protein gene that's placed into the phage so that the modified coat protein and the foreign peptides are expressed on the phage surface. Now T7 resembles the T4 bacteriophage, also with the foreign peptide sequence, the modified coat protein sequence, and then the expression of the foreign peptide on the phage surface. So that's how these phage libraries are made, and then we can amplify these phage, use antibodies that capture the bound peptides on the phage that happen to express these. Then these can be immunoprecipitated or placed on, we can use beads and various technologies to separate only those phage that happen to express a peptide that reacts with our antibody. Then these phage can be sequenced so that we can find out what that peptide is. So that's basically how this technology works. These libraries contain hundreds of thousands of different peptides, and this is a tremendous tool to study protein-protein interactions. Now it turns out that paraneoplastic neurological diseases are fairly common, and in the study that I'm going to show you, a phage display was used to elucidate what the mechanism was of a paraneoplastic neurological disease. And some of these have been already previously described, including an autoantibody against the paraneoplastic antigen MA2, but in the particular study that I'm going to show you in a moment, the antigen was something entirely different. And this paper in the New England Journal involves a 37-year-old man with a history of a seminoma, a testicular cancer. This is treated with the conventional care that's usually quite successful in treating patients with seminoma. But after his treatment, this patient develops a vertigo, ataxia, and double vision. And a phage display was used to show that his autoantibody reacted with a protein called Kelch-like protein 11. The Kelch proteins are ubiquitin ligases, and they're involved in garbage disposal mechanisms inside cells. That's what ubiquitin ligases are for. The investigators then, who are from Olmsted County, Minnesota, in other words, Mayo Clinic, looked through their entire records of men with seminomas and found other patients that had had neurological symptoms that had not been clarified, and they found that these patients also had antibodies against Kelch-like protein 11, and that's what this is about. So these are, in addition to the index case, here are 12 other patients that had various neurological symptoms involving ataxia, dementia, double vision, etc. Then the investigators were able to use mouse brain tissue to find an interaction here with these antibodies, and also the mouse equivalent of Kelch-like protein 11. And Western blots for the autoantibodies are positive in cerebrospinal fluid and serum in some of these patients. So this is an example of using phage display to find antigens for autoimmune disease, but the whole business can also be used to elucidate other protein-protein interactions, and I think this is terribly exciting, and that's why this paper was published in the New England Journal. Now, an image in the New England Journal involves this poor 2.5-year-old who had a seizure, and then it looked like he had a cardiorespiratory arrest, so he was resuscitated with the appropriate means, and the resuscitation resulted in a gastric rupture and this pneumoperitoneum. But the gastric rupture was operatively repaired and the infant did well. Now here's the image from last week, which involves this poor lady's rear end that seems to itch a lot. And this is an example of anaerobius vermicularis, which is generally a disease of children. And her 5-year-old had this too, and these are the typical eggs that are laid by anaerobius vermicularis, and oral albendazole solved the problem. Now the review in the New England Journal involves nasal polyps, which are common. And this is a common ENT problem. These patients have a lot of symptoms, inflammation, nasal obstruction, and if you look inside their nose, you can generally find these polyps, but with modern endoscopic techniques, a lot better than what we used in the old days, these polyps can be elucidated. So this is an extension of chronic rhinosinusitis, and the patients can be treated with particular saline irrigations or glucocorticoids, and some of these patients have to be operated upon. And inflammatory cytokines, as we could imagine, are involved in the development of this condition. Now, idiopathic nasal polyps are more common in men than women. Now, we know that nasal polyps are also a feature of aspirin administration, and aspirin-exacerbated respiratory diseases are more common in women compared to men. And there are also fungal rhinosinusitis and vasculitis, ankylosing, commonly involves nasal problems. Patients with cystic fibrosis and patients with atopic allergic diseases also feature nasal polyps, and so that differential diagnosis has to be kept in mind. And imaging techniques has helped substantially in showing the development of these polyps that stem from the inferior, middle, or superior turbinate, as shown here. And the author gives an algorithm that you can, a treatment algorithm that can be applied for patients that have these kinds of nasal polyps. Now, another review in the New England Journal involves, this is part of their Frontiers in Medicines service, and this one is entitled Genetic Variation, Comparative Genomics, and the Diagnosis of Disease. This sounds fairly formidable, but the first thing that we have to do with this kind of problem is to learn what language these people are speaking. And once we've learned their language, we can understand what they're talking about, and then we can deal with their material. So I spent a lot of time on the glossary. This is the jargon that these genomics people use. And I've highlighted some of the jargon here. Comparative genomics. Now we can compare the genome to other species, or we can compare the genome to other members of our species to look for differences. The reason that some knowledge in this area is important is because to sequence the genome today costs less than having a magnetic resonance imaging study performed. The sequencing is cheap, but understanding what the sequencing means is substantially more expensive and important, and that's why we have to know something about it. Copy number variations. These are common. Whether or not they mean something is another question, and we're going to discuss that in a little more detail. Genome-wide association studies, where genetic variants are used that are scattered across all the chromosomes, are used to find areas of the genome that are associated with a particular phenotype or a particular disease. GRCH38 is a representative human genome sequence that's highly annotated and the sequence is made up from numerous genomes of normal individuals. But we also have a database of 1,000 normal human genomes that we can use in our comparison if we compare one genome to normal individuals. You should know what a haplotype is. You should know about insertions, deletions, and the differences between very small ones and larger ones. These are the terms, and we have to come to grips with them, but you know most of these anyway. In these genome-wide association studies, single nucleotide variants or single nucleotide polymorphisms are used to find areas of the genome that are associated with a particular phenotype. Structural variants are up to 50 base pairs in length, and whether or not they have a meaning is a problem that we then have to determine. An example given in this review is color blindness or red-green color blindness. And here are various examples of mutations that occur in individuals that have red-green vision alterations, and they involve stop codons, and they involve inversions, and they involve various things that affect the red cones or the green cones, and you can look at these things in detail here. So we're now aware of 5 million single nucleotide variants scattered across the 3 billion base pairs that we have in the genome. And the insertions and deletions that we have are also well known, and there are only 800,000 of those. And inversions are also fairly common. And multi-copy number variants have also been mapped. And various ethnic groups are different in terms of their short read sequences and long read sequences, and all these genomes of these various subgroups can be downloaded from the internet, so you can make your appropriate comparisons. And complex variants resulting in genetic disease, Mendelian disease, or other copy number variations, expansions and these various things, repeat expansions, and particularly in neurological diseases, all of these things are discussed here. And the directions in which this research is liable to go in the next 10 years is also a topic of this discussion. Now, the case in the New England Journal underscores the fact that even if people have a well-known Mendelian genetic disease, that fact doesn't necessarily protect them from other diseases. So the patient of the week involves a 22-year-old woman who has sickle cell disease. She has typical sickle cell disease. And sickle cell disease commonly results in stroke, which results in vascular changes within the brain supplying vasculature. And she also has moya-moya syndrome. That's a Japanese word, and we'll take a look at what that means. And she shows up with complaining of progressive weakness. She has difficulty climbing stairs and difficulty even in lifting her head. And the problem seems to be symmetric, and it largely involves the axial skeleton. She has no problem with cognitive impairment, paresthesias, numbness, or urinary incontinence. She also reports double vision, which should be a red flag. So this woman has double vision. So on the neurological examination, she has ptosis of the left eye, so she can't lift her eyelid very well on the left side. So ptosis and double vision in a patient should probably immediately suggest to you what this patient is likely to have. Now, she has a good neurological examination, so the examiner also uses a red lens to compare the two eyes, and then has her look to the right, to the left, and top to bottom to replicate her complaint of having double vision. When she came into the clinic, she seemed to be hypoxemic, and somebody immediately put an oxygen mask on her face instead of trying to figure out why she's hypoxemic. But we know now why she's hypoxemic. Her routine blood work shows that she has a serum bicarbonate level of 37 millimoles per liter. And she should immediately have blood gases done. Those were done. And her PCO2 is 66. So it looks like she has respiratory acidosis. And her PO2 with 2 liters of oxygen is 163 millimeters of mercury, which we would expect. Now she sounds like she ought to have myasthenia gravis with ptosis and double vision and this form of weakness. But testing for the acetylcholine receptor binding antibodies was negative, which confused me because I really wasn't aware of antibodies against muscle-specific tyrosine kinase. And antibodies against muscle-specific tyrosine kinase also result in myasthenia gravis, and I didn't know that. So she has an EMG done, and with repetitive stimulation, the signal gets weaker and weaker. Not that impressive. I've seen more impressive examples than this, but she doesn't have antibodies against the acetylcholine receptor. She has an antibody against muscle tyrosine kinase. And she has a biopsy done, and we see atrophy of some muscle fibers shown here. So both myasthenia gravis associated with antibodies against acetylcholine receptor and the muscle-specific tyrosine kinase causes fatigable weakness. But there are clinical differences. For instance, this patient responded relatively poorly to pyridostigmine, which is generally not the case in patients that have acetylcholine receptor antibodies. Now, we might imagine that an antibody-mediated disease would get better with rituximab, and this patient also got better with rituximab. So this muscle-specific tyrosine kinase is involved in the placement of the acetylcholine receptors on these end plates. And so if these 2 red guys here aren't working properly because of an autoimmune disease, then these blue guys here aren't properly placed into the membrane so that signaling with acetylcholine is impaired. And this moya-moya disease results in vascular changes that are seen here, that would be fairly expected in patients with sickle cell anemia that results in stroke. Now, the first paper in the Lancet involves treatment for multiple myeloma, and the treatment nowadays is called VTD, which includes bortezomib, thalidomide, and dexamethasone. And these patients are generally also subjected to autologous stem cell transplantation. Now, we know from earlier studies that another effective treatment is an antibody against CD38, which is expressed on many cells, but particularly on plasma cells. So that this is a specific plasma cell, anti-plasma cell therapy. And since multiple myeloma is a plasma cell malignancy, this sounds like a good idea. So 111 European sites participated in this study, and daratumumab is an antibody that's directed against CD38. So here are the patients, and they had various forms of myeloma, and they got better. But the patients that got the antibody against CD38 got more better than the patients that got standard care. So this is progression-free survival. Both groups did pretty well, but the patients that got the antibody did better. And after their autologous bone marrow transplant, this advantage was continued to be apparent. And various subgroups are shown here. So everybody that got the antibody did better. So I think that in the future, this antibody will be incorporated into the general care of patients with multiple myeloma. Now, the next topic at the New England Journal involves GLP-1 receptor agonists. And these compounds, very interesting compounds, stimulate insulin release, and they inhibit glucagon release, and these effects lower blood sugar. Now, these glucagon receptor agonists also interact with DPP4, which are enzymes that inactivate incretins. And these incretins were first isolated from this organism here, the Gila monster, which is a feature of living in Arizona. So that's where he's from. So liraglutide or incretins have to be given by injection, with one exception, a new compound, and I don't know exactly how this works. I'm not quite sure how this compound is absorbed, but this is semaglutide. And the question is, if we could develop an oral form of incretins, that would be much more acceptable by the patients. So in this study, oral semaglutide was compared to liraglutide. And here are the patients, 284 in one group, 285 in the other, and these are patients with pretty bad type 2 diabetes, and there are various ethnic groups, and they have elevated hemoglobin A1C levels, etc. And some of them, about a quarter, are also getting SGLT2 inhibitors, and we know that those are effective in the treatment of type 2 diabetes. But with the administration of both forms of incretins, oral or subcutaneous, we see an additional drop in hemoglobin A1C, which is not bad. A 1% drop is about what we would expect. And that, if anything, looked a little better in the semaglutide group compared to liraglutide, both quite a bit better than placebo. The other thing that is even more impressive is how much weight the people lost on incretins. But the weight loss on the oral form of incretin was 5 kilograms, which I think is pretty respectable. So if anything, and various subgroup analyses are shown in this fairly complex table that you can examine on your leisure, at your leisure, and adverse events, the oral form was at least as well tolerated as the systemic form of incretin therapy. So this looks like a substantial advance in the treatment of type 2 diabetes in terms of acceptability for the patients. Now, the next study in the Lancet involves the treatment of patients with stroke, and robot-assisted rehabilitation mechanisms are now in vogue, but as you can imagine, they're fairly expensive if we compare to physiotherapy alone. And in this particular study, the effectiveness of robot-assisted training for the upper extremity rather than gait, as I show here in these examples, was tested. And so this was a multi-center randomized controlled trial of stroke patients that had paralysis or paresis of one extremity to see whether or not a robot training would be better than usual care with physiotherapy. And the robot training couldn't beat physiotherapy. So it doesn't look like a great advance here, but these things also have to be tested because they're expensive. So the results of this trial did not support the routine use of robot-assisted training for the upper extremity in these patients with stroke. Now, the review in the Lancet involves an Epstein-Barr mediated nasopharyngeal carcinoma. And this is not the major problem in Germany or in the United States, but this is a common malignancy, and it's initiated by Epstein-Barr virus, which was discovered in patients with Burkitt's lymphoma. So we might imagine how this tumor works. So this is an Epstein-Barr related disease that results in a bad malignancy that requires chemotherapy and radiotherapy and is a major problem in numerous parts of the world. And so if the primary tumor is staged and regional lymph nodes and distant metastases, and these a whole series of investigations have been done primarily in the Far East in patients that have this problem, and they have to be treated with cisplatin and other fairly complicated cancer treatments that are also associated with a lot of side effects. So a lot of work needs to be done on this problem. So there are lots of research questions that are germane here. The second review in the Lancet involves scabies. And scabies is a skin disease that's caused by this burrowing mite. And mites are arachnids. That means that they're spider-like animals, and so they have 8 legs. They're not insects that have only 6 legs. They have 8 legs. And they burrow underneath the skin, and they elicit an incredible amount of itching. And we can see this, the results of that in this poor patient here who has scabies of both feet. Scabies was an amazing medical problem in the 19th and in the early portion of the 20th century. In many countries, it's sort of been forgotten, but it shouldn't be, because scabies is still around. And scabies can be treated very effectively with ivermectin. Moxidectin is better because moxidectin has a long duration of action, because the eggs laid by these mites take a couple of weeks to hatch. So if we treat our patients with a single dose of a drug, we'd like to have a drug that is around for a long period of time so that the eggs that are likely to hatch are also destroyed by the drug. So here's a young child that has scabies. Now the diagnosis, I was taught to scrape these lesions, little potassium hydroxide to get rid of the chitin of the skin, and then to look for evidence of the scabies mite in terms of finding its extremities or mouth parts of things of this nature. That is a effective diagnostic tool, but you have to have practice in doing this. And these are the scabies areas, and this is mostly in the tropics. And Australia has a major scabies problem, not in the European population, but in the endogenous Australian population, where there's a whole lot of scabies. And in the associated tropical islands that are illustrated here, scabies is also a major problem, although it's present all over, and we have to think about it so that because we have effective treatments for scabies, so this problem could be combated. And we'll stop with this report in the Lancet. This is a 90-year-old woman that shows up with nausea, vomiting, and belly pain 50 years after having had a cholecystectomy. She also has atrial fibrillation and other problems. So she had a cholecystectomy 50 years ago. So she has this CT scan, and we see this huge dilated stomach that's filled with fluid. Then here's the pylorus, and then here is this structure in the very upper portion of the duodenum. And this looks like some sort of a stone. And so she was operated on, and indeed this stone with these multiple layers that are evident in the CT, and this is a gallstone. Now what is a gallstone doing here, causing gastric outlet obstruction in a woman that had her gallbladder removed 50 years ago? Interesting question. And this condition is called Bouveret's syndrome. I've never seen this. I'm aware of gallstone ileus. These stones usually land in the terminal ileum and cause obstruction, but they can also lodge in the top portion of the duodenum and result in gastric outlet obstruction, and that's called Bouveret's syndrome. So perhaps the stone has been there for 50 years, but more likely it probably formed an cystic remnant and resulted in a choledochal duodenal fistula that resulted in this gastric obstruction. Here are some other examples. Here's another stone, dilated stomach. So now you've heard of Bouveret's syndrome. That's it for this week. Come back next week and we'll find out what they've discovered in the meantime. Thank you for your attention.